Ray and Darren. And children with medical complexity are at increased risk for early developmental delays, and the longer-term outcomes of these delays have not been well studied. A more in-depth understanding of the early childhood and preschool needs of high-risk children is important to plan therapy and educational services. So the purpose of this study was to evaluate patterns of learning in medically complex neonatal and cardiac intensive care graduates through 3.5 to 5.5 years of corrected age. This was a prospective longitudinal study of infants at high risk for motor impairments, and the groups we included were those who were extremely preterm, those who had congenital heart disease requiring early surgery, those with neonatal neurologic abnormalities such as IVH or HIE, and those with prolonged hospitalization through 10 weeks corrected age. The majority of the infants in our study met more than one of these enrollment criteria or had some degree of prematurity, multiple surgical procedures, genetic syndromes, or were technology dependent at discharge, and therefore we consider them to be medically complex. The infants were enrolled prior to the first visit to our developmental follow-up program. They were evaluated at 18 to 24 months corrected age using the Bayley Scales of Infant-Toddler Development, 3rd edition, including the cognitive, language, and motor composite scores, and at 3.5 to 5.5 years corrected age using the Differential Ability Scale 2, and this has cluster scores for verbal, nonverbal, and spatial cognitive abilities. The verbal cluster includes verbal comprehension and naming vocabulary. The nonverbal cluster includes picture similarities and matrices, and the spatial cluster includes block designs and copying, which assesses visual, motor, and fine motor skills. Both the Bayley and the DAS are standardized to the normal distribution that's shown here. And in the normative population for the test, the mean is 100 and the standard deviation is 15. For this study, we considered a score less than 80 to be a delay, that's less than the 9th percentile. And we considered uneven development to be a difference between the cluster scores of more than one standard deviation or greater than 15 points. So an example of this would be for one of the children in the study had a verbal score of 93 and a spatial score of 72. So this child had both a delay in spatial abilities and an uneven development because this score is 21 points higher than the spatial score. So 120 children presented for the 3.5 to 5.5 year visit. And of these, 96 were able to complete 2 or more of the DAS clusters. And 24 or about 20% of the patients were not able to complete the DAS testing. And some children were not able to obtain the basal criteria to continue the test. And sometimes their function was too low for any test, and sometimes they required a different test, such as the Bayley or a younger version of the DAS, or received a partial test. For 7 children, the test was not valid or not administered. So when we look at these 2 groups, there weren't any differences in the sex, gestational age, enrollment criteria, or any of the neonatal conditions that we looked at, but we did see that severe impairments were more likely in the group that did not complete the DAS testing, as more had motor impairments or autism. Turning to the cognitive delays, at 18 to 24 months, this graph shows that only about 4% of the patients showed a cognitive delay, whereas these delays increased to about 23% using the DAS at 3.5 to 5.5 years. So there was a significant increase in the number of children with cognitive difficulties. And none of the children who had a Bayley score less than 80 improved. Looking at the specific DAS clusters that we evaluated, the verbal, nonverbal, and spatial delays are shown here. The verbal delays were most likely, And for the next slides, looking at uneven development, remember that the verbal to nonverbal differences, or verbal to spatial differences, or nonverbal to spatial differences are what we're looking at. So in terms of uneven learning patterns, we saw that these were quite common, and 45.8% of children had uneven learning patterns. They were not associated with sex, neonatal medical or neurologic diagnoses, cognitive, language, or motor delays at 18 to 24 months. They were not associated with uneven development at 18 to 20 more months. And they occurred equally likely in children who were delayed on the DAS and those who were not delayed. They were more common in children with cerebral palsy. And although we were not able to establish that there were any neonatal or earlier antecedents of these, we did see that they were associated with functional difficulties, as the risk of, or the odds of needing an individual education plan was increased in children with uneven development. And an individual education plan in the United States is a package of special educational and therapy services that are offered by the school system. And within those services, the use of occupational therapy was also higher in children with uneven development. PT and speech were not increased. And then just finally to show, at the time of this visit, about 30% of the children were recommended by the clinical team to have new or additional services. And so out of this 96 patient part of the cohort, about 55% ended up with services at the end. So in summary, in this high-risk group of children, cognitive delays evident at 18 to 24 months did not improve, and more delays emerged over time. Although only 22.9% of children had low verbal, nonverbal, or spatial abilities, 45.8% had uneven patterns of learning. Uneven patterns of learning occurred. Let me go back. Nope. Uneven patterns of learning occurred in children who required higher needs for special education and occupational therapy, but were not associated with any neonatal characteristics. Because of these functional associations, we feel it is important to do further assessment of these uneven learning patterns to see if they may be associated with learning disabilities or attention problems later. And finally, our psychologists feel it's important to continue neonatal follow-up. Many programs end at about 2 years, and as we can see, the children may have distinct patterns of strengths and weaknesses and continue to require supports at school age, so it's important to continue to follow them. Thank you.